Good evening, everyone, and welcome to this wonderful evening with Dr. Murali Bharadwaz. I hope you all have downloaded the Incus learning app and taking the daily mock test so that 100 MCQs, a mini-sized mock test like mini idli, mini dosha, 100 questions in the morning, full scale. Image-based questions, case study-based questions, quick, with the gun on the temple kind of single liners, everything combined, just like the NEET PG. And in the next 36 days, you are going to solve almost 4,000 questions in this 40 grand tests. And these are the most expected questions and topics in the tomorrow's NEET PG. Out of 200 questions, 170 questions are going to come from these 4,000 questions we are going to discuss in the next 37 days. So that is the reason I always tell you, after you finish the test and the discussion, identify 5 to 10 topics. Where am I going wrong? And improve on that. That's all will play the magic to see you becoming the topper. Chalo, shuru karenge. Tam bola for the today's wonderful evening. You can punch the answers so that your life interactive. Some points that come to your mind, keep typing them. That makes you vibrant, right, Doc? So thanks for joining this evening. This session is supposed to start at 6 o'clock, but a little late, but late is better than never. Yes, so let us start with good to see Abharanam and many more who are all online. Yes. Munchausen syndrome is a type of factitious disorder. So basically it is a malingering in which the patient may practice self-mutilation and deception to feign the illness. Paranoid delusions. What are paranoid delusions? The delusion of reference, the delusion of persecution, delusion of grandeur, they're all paranoid. Nihilistic delusion is a delusion that you come across when there is depression. So the people who have nihilistic delusion, typically, they think the world is ending. There is no NEET PG. Only next exam. Seat nahi, is saal entrance nahi hoga. They're all nihilistic delusion. That is, world is going to come to an end. Is a nihilistic delusion. A form of psychotherapy in which a group of patients act out the assigned roles, and while doing that, they will gain the insight into their own mental disturbance. What is this called? This is called psychodrama. So you should know psychodrama, psychocatharsis. What is catharsis? Catharsis is something to purge out all the internal conflicts. So whenever there is any traumatic experience, you know that every psychiatrist has got just like a dental chair of a dentist. They have a bed where the patient is leaning down and telling all the childhood experiences. So all those which are hidden, subconscious level, they are being brought out when the psychiatrist is asking the questions and letting out those hidden emotions, which is called psychocatharsis. Delirium and amnestic reaction. Where do we see? Typically, alcohol, delirium tremens, all of you know very well. Alzheimer's dementia is more common in females in the first degree relative with the disease. Any past history of head injury is a risk factor, and Down syndrome get pre-senile dementia, which is like Alzheimer's type of dementia, is what you should remember. So female gender is considered to be an important risk factor for the development of Alzheimer's. Snowstorm appearance, where do you see that? Hydatiform mole. Bamboo spine appearance, you see it in ankylosing spondylitis. In the chest radiograph, what are you able to see, doctor? Axial calcification, which is seen in the case of the silicosis, sarcoidosis, lymphoma, in any of these conditions. Now, what is this skull radiograph and where do you see this? This is basically the multiple calvarial defects which you see in the case of the multiple myeloma is what you need to remember. So that is the reason it is a paraproteinemia. You need to get the total serum protein done. Now, what are you seeing here? So there are two signs. Banana sign, where the cerebellum is being aplastic and stretched out in the shape of a banana, and the lemon sign. These are the signs you see in the case of the neural tube defects. So where do you see neural tube defects? Whenever there is any maternal folate deficiency is what you should remember. Thromboangiitis obliterans. Typically superficial thrombophlebitis is seen. Raynaud's syndrome is associated with it. It is the middle and small sized vessels which are obstructed in the case of the thromboangiitis obliterans is what you should remember. Sigmoid volvulus, in which direction rotation occurs? It is the anti-clockwise rotation in which the volvulus typically undergoes a rotation. And on the barium enema, bird's beak or ace of spades deformity is what you typically see. Omega loop sign, otherwise called bent inner tube, is a X-ray finding. And what is that procedure done in the case of the sigmoid volvulus, doctor? Paul McCluke's procedure is useful whenever there is any impending gangrene, is what you need to remember. So jabule and hydrocele, you all remember everting the sac and all the sunset colored fluid of the hydrocele comes out. He belongs to France. So sometimes exam like NEET PG, there can be some questions that will baffle your confidence. Father of bacteriology, Louis Pasteur. Father of epidemiology, John Snow. Father of Indian surgery, Shushruta. Father of modern surgery, Ambroise Paré. Father of Indian medicine, Charak. Father of modern medicine is Hippocrates. Father of anatomy is Vesalius. Father of physiology is Claude Bernard. So sometimes ये सब इसे बट्टी मारने का होता है. Father of psychoanalysis is Sigmund Freud. Homeopathy is Hahnemann, and antisepsis is Joseph Lister. Maybe they will ask who is the father of COVID this time. Now, germ cell tumor, which is not common in young males. Lymphoma is more common in elderly patients. Most of the secondaries that go to the bone, where do they originate, doc? Carcinoma of the breast. Abhi shuru ho gaya? In this, you need to master some important facts about the secondaries, etc., etc. 80% of the metastatic lesions are from the primary carcinoma, particularly breast, prostate, lung, kidney, thyroid, pancreas, stomach in that order. The most common primary source of the solitary skeletal metastasis, at the time of the first diagnosis, is carcinoma of kidney. Most common site of the bony metastasis is from the breast, and it goes to lumbar vertebra. The most common quadrant in the carcinoma breast is upper outer quadrant. Then osteoblastic secondaries. What are the most commons you want to remember? In males, prostate cancer. In females, breast cancer. And in males, osteolytic is lung cancer. In females, once more, breast cancer. Then there are vascular expansile metastasis, which you need to remember. So, thyroid, renal cell carcinoma, they form. Lytic expansile metastasis is what you need to remember. From where does carcinoma prostate arise, doc? It is the posterior lobe. Seagull sign is seen in the case of gallstone, where there is a gas in the gallstone, which will give that Mercedes-Benz sign typically. Similarly, what is Murphy's sign? If you do a deep palpation of the right upper quadrant, the patient complains of acute pain during deep inspiration, which is called Murphy's sign. Beauvois sign is seen in acute cholecystitis. Whenever acute cholecystitis, there is gallbladder inflammation, right? Cholangitis means bile duct inflammation. Be very sure. So, when acute cholecystitis is there, there is a hyperesthesia between the 9th and 11th ribs posteriorly on the right side. That's the point you need to appreciate. Hypertrophic pyloric stenosis in an infant. It is associated with erythromycin. So, if you give erythromycin in neonates within the first 2 weeks of life, then they are predisposed to the hypertrophic pyloric stenosis. Testicular torsion. Why does it happen? Whenever there is a high investment of tunica vaginalis, which is called bell clapper's deformity, is the most common form of underlying cause for the testicular torsion, which is a surgical emergency, is what you need to remember. Mantle radiation, where do you give, doc? In case of Hodgkin's lymphoma. So it is an extended field radiation, which is called mantle field. In Guillain-Barré syndrome, it is autoimmune. Post-infectious demyelinating polyneuritis is called Guillain-Barré. Facial nerve palsy can be associated. Immunoglobulins are considered a treatment of choice. And which infections are known to be associated? Campylobacter jejuni, herpes virus, CMV, mycoplasma, rabies, etc., they're all associated. Now, Miller-Fisher syndrome. What is the triad of clinical features of this Guillain-Barré variant, Dr. Miller-Fisher is a favorite question. Ataxia, areflexia of the limbs without weakness, ophthalmoplegia without pupillary paralysis. This is the combination which is called Miller-Fisher syndrome, is what you should remember. Anti-GQ1B antibodies are the ones which are found in the case of the Miller-Fisher syndrome. CVP, where does it rise, doctor? In cardiogenic shock, the central venous pressure increases. Salivary gland stones, most commonly, it is a submandibular gland. Ureterosigmoidostomy. Typically, you see hyperchloremic, hypokalemic metabolic acidosis. It is also called normal anion gap metabolic acidosis. Normal anion gap metabolic acidosis is what you need to remember. Whenever there is a carcinoma of the anal canal, it is a chemoradiation which is considered to be the management of choice. Injection sclerotherapy, where do you give that? Internal hemorrhoids. Good to see Achenchan Khan, wonderful luck. Now, you invite all your friends, and let me tell you once more, doctor, March 5th to April 15th, 40 days, 40 daily grand tests on the Incus app. Please take every chance to download the Incus app. Take this 40 daily grand tests. Morning up test le lo. Our sham 6 to 7:30 p.m. we will have a quick discussion and identify what are 10 to 15 topics where you are going wrong and revise. You follow me all the 40 days. I will give you most probable MCQs, 4,000 most possible MCQs, using all my experience of this past 22 years. Almost 170 questions come from these topics only. That's more than enough. That's how you become a winner. So, doctor, lung cancer, pancreas, GI cancer lead to migratory thrombophlebitis, which is called the typically the feature of internal malignancy. Then what is Rozier's sign? So whenever there is a GI malignancy, then left supraclavicular lymph node enlargement is called Rozier's. And how do you make the confirmation of the diagnosis of a congenital megacolon? Rectal biopsy. And if you do rectal biopsy, you can see hypertrophied nerve bundles, absence of ganglion cells, etc., etc. Staghorn stones, they are composed of triple phosphate. So typically the stones grow in the alkaline urine, especially when proteus organism is present, which split the urea into ammonium. Then uric acid stone, urate caliculi. You should know they are multifaceted, radiolucent, form in acidic urine. Cystine caliculi, hexagonal, translucent, appear only in acidic urine, and they are very hard and radio opaque because they contain the sulfur, is what you should remember. Xanthine caliculi, smooth, brick red in color, show lamellation on the cross section. They're all the true statements. Then coming to the inflammatory bowel disease, you should remember in Crohn's disease, if you happen to do the TPN, especially when Crohn's is transmural, Crohn's lead to fistulas. So those high output fistulas, whenever they develop in the case of the Crohn's, the TPN promotes the closure of the fistula, is what you should remember. Is my voice loud and clear, Doc? Yeah. So if my voice is not loud and clear, please let me know. Can online students can punch where the voice is loud and clear? Now, doc, a 54-year-old non-bilious emesis upper GI radiograph is being shown. So, what is this typical appearance? Like a stack of coins. It is the intussusception is what you need to remember. So, exploratory laparotomy, manual reduction and resection of the involved segment, that is considered to be the part of the management way. Surgery is the mainstay for the symptomatic adult intussusception is what you need to remember. A 59-year-old underwent pelvic radiation therapy. Now, after right hemicolectomy for villus edema, the surgical wound is red and tender. The drainage is persisting. So, what is the most likely possibility? So, most of the times, the enterocutaneous fistulas, they're all iatrogenic and they result from the anastomotic leakage. Good to see Dr. Anupama and many more who are all online. Good, doctor, good. So, in this case, there is an anastomotic leakage after you have done the right hemicolectomy with the enterocutaneous fistula, which actually explains. Now, with regard to the appendicitis, to make the diagnosis of appendicitis, a lot of times it is the most baffling diagnosis appendicitis is. So, the base of the appendix can always be found at the confluence of the cecal tinea. So you should remember, the cecum becomes fixed in the right lower quadrant. So typically, the right lower quadrant, the cecum becomes fixed. And the appendiceal orifice is at the base and the anti-mesenteric confluence of cecal tinea. That is the place where appendix orifice is located. So that is the reason these anterior tinea become the landmark to find the appendix during surgery. And where is the tip of the appendix? Most of the times the tip is retrocecally located in majority of patients. But when a woman is pregnant, the gravid uterus will push appendix superiorly and the tip medially. That's the point you need to appreciate. Coming to the pathogenesis of appendicitis, there can be viral infection, bacterial infection, which can proceed in appendicitis. There can be an obstruction of the venous flow and then arterial inflow that lead to gangrene of the appendix. And it is the anti-mesenteric border which has the poorest blood supply, and the site of the perforation of the appendix is what I want to underscore to all of you. Now, if you look at the feculates, most of the times, feculates are the underlying cause in case of the adults, not in young children. Whereas in the case of the younger children, it is the lymphoid hyperplasia, which is the cause of the obstruction, is what I want to underscore to all of you. Now, with regard to peritonitis, you should know that primary peritonitis versus secondary peritonitis. What is the difference between the two? Let's look into it. Without any intra-abdominal source, when peritonitis occurs, it is called primary. It is often seen in case of the children. Commonly, pneumococcus, hemolytic streptococci are responsible. Whereas in the adults, it is the cirrhosis and ascites. Similarly, those who are managed with peritoneal dialysis, they are at the risk of developing the E. coli and Klebsiella associated peritonitis is what you need to remember. So, doctor, without loss of integrity of the GI tract, it's called primary peritonitis. It often occurs in adolescent girls. Streptococcus pneumonia is the commonest organism. Whereas GI perforation, anastomotic dehiscence, pancreatic necrosis, any of them can lead to the secondary peritonitis. Both aerobes and anaerobes are involved. E. coli and Bacteroides fragilis is what you see in case of the secondary peritonitis. So now, doc, whenever you are suspecting primary hyperparathyroidism, what are the investigations you want to do? You want to do a PTH, intact PTH level, serum calcium level, serum vitamin D level. Only important thing about parathyroid is, before you interpret the parathyroid function test, you want to know whether it is primary hyperparathyroidism due to parathyroid adenoma or whether it is a secondary hyperparathyroidism due to an underlying renal failure. That's the reason always renal function test should be done. Then generally urinary calcium levels are not done while evaluating the hyperparathyroidism. Generally hyperparathyroidism is equal to hypercalcemia is what you need to remember. So, if a patient is having family history of hypercalcemia, so in such people there is an entity called familial hypercalcemic hypocalciuria. Because of a decreased excretion of the calcium into the urine, there is an excess calcium in the plasma, which occurs familially. There you have to do the 24-hour urinary calcium. Otherwise, routinely, whenever you are evaluating hyperparathyroidism, there is no need of doing the 24-hour urinary calcium is what you need to remember. Once more, doctor, you need to go back to the Incus 2000 HD videos. You have in general medicine around 150 20-minute videos are there. One of them in endocrinology is hyperparathyroidism. Tonight only you have to do the revision of that because definitely aane wala topic hai. Coming to the rectum, colon, anatomy, histology, you should know everything. The ascending colon, descending colon, they are usually fixed to the retroperitoneum. So, you should know that when the rectum, sigmoid colon and rectum combine, that's called rectosigmoid junction. The three tinea coli, they become broad, fused together, and the rectum is totally invested with two complete muscle layers. The reason sigmoid colon may develop the diverticulum, colon may develop diverticulum, but not the rectum. So diverticulae do not form in rectum because it has got two complete muscle layers that prevent any outpouching from the wall is what you need to remember. Now, one thing you should know is in the colon you have plicae semilunaris. They are spaced, transverse, crescentic folds that separate the tissue between the tinea coli and form haustray. So they produce a characteristic intermittently bulging pattern that helps to differentiate the colon from small intestine. So plicae semilunaris is there in the colon, whereas plicae circularis, also called valvulae conniventis, they are the complete circular. They are crescentic. Crescentic bole to not full circle. So completely circular mucosal folds are called plicae circularis or valvulae conniventis is what you see in the case of the small intestine. So typically plicae semilunaris. So where do you find this is colon? Whereas complete circular groove, plicae circularis is the feature which you find in the case of the small intestine is what you need to remember. So unlike semilunaris, circulates traverse the full diameter of the small intestine. That's how you identify them radiologically. So now, doctor, in this context, you should know this Garmadharam question. So you need to take a quick snap. Even on the Incus learning app, all this PowerPoint is available for you to do the revision. You can always take a print screen if you want to really bookmark something, the images, tables. You can always print screen the PowerPoint slides on your mobile phone, right? But otherwise, yahan print hona hai, doctor, that is important. Where do you find villi? Small intestine. Circularis, small intestine. Semilunaris, large intestine. Then tinea coli, they are positive in large intestine except appendix and rectum. Then hostrae and sacculation is a feature of the entire large intestine. Then appendices, epiploicae, they are positive in the large intestine except in cecum and rectum. Then peritoneal relation. Small intestine is an intraperitoneal organ except the duodenum. Large intestine is a retroperitoneal organ except cecum, transverse colon, sigmoid colon and rectum. Then peritoneal fold. There is a mesentery proper except for duodenum. Then in the case of the large intestine, you have a transverse mesocolon and sigmoid mesocolon is what you need to remember. Now, cecal diverticulum versus sigmoid diverticulum. What is the difference between the two? Cecal diverticulae are considered congenital in origin. Whereas sigmoid diverticulae, they lack a muscular component. That's the reason they are not considered as true diverticula. And whenever cecal diverticulitis happen, the closest differential diagnosis is acute appendicitis. Clinical picture will be similar. And for both the types of diverticulae, whether it is cecal or sigmoid diverticulae, the surgical therapy is not required if the diverticulum is incidentally discovered. This is one of the favorite MCQs. Surgeon is operating or did a radiological evaluation and then he found that there is presence of the diverticulum. What do you want to do? So what you want to do is the question of the examiner. Is there any? Yeah. So what is your answer, doctor? Surgical therapy is not required if it is an asymptomatic diverticulum incidentally found when you are doing the evaluation is what you need to remember. So what is an indication for colonoscopy? If there is 8 to 10 years of ulcerative colitis history, you have to do colonoscopy. Hereditary non-polyposis colorectal cancer, all family members need to undergo. Surely patient with adenomatous polyp found in the upper part of the rectum on sigmoidoscopy, you have to do colonoscopy. Whereas patients with chronic colitis, you don't do colonoscopy to monitor the treatment. Clinically only you can be able to monitor the treatment. Now, doc, colorectal polyps. You should remember, hyperplastic polyps are the most common type. And the mitosis in hyperplastic polyps, it occurs at the depth of the crypts is what you need to remember. Now, you have neoplastic polyps like tubular adenomas, tubulovillous adenoma, villous adenoma, etc., etc. But what is the most common type of all polyps? Hyperplastic polyps are the most common type of all polyps is what you should understand. And what is the size criteria? When is tubular adenoma should bother you, when it should not bother you? If it is less than 1 centimeter in diameter, it won't harbor malignancy. 1 to 2 centimeters, 10% cases. And larger lesions, larger than 2 centimeters, 30% cases there can be malignancy. And one word you try to remember, doctor, that what is the classification called as? The classification of the adenomas, cancer containing colorectal polyps. It's called Haggett's classification. Haggett's classification, right? Now, inferior dislocation of the shoulder. It is the axillary nerve which is injured. These are all biscuit questions. Anti-dislocation, why does it happen? Abduction, axial rotation will lead to. Abduction and axial rotation will lead to. If you are abducted, axially rotated, then that lead to the development of the anterior dislocation. Whenever a person falls on an outstretched hand with the limb in the lateral rotation, so that the head of the humerus is forced against the anterior capsule, as what you can see here, is the common mechanism of anterior dislocation. Then posterior dislocation. It is a forceful medial rotation. Suppose a player is trying to catch the football, fell on his elbow, and a forceful medial rotation is there. That leads to posterior dislocation. Then similarly, epileptic attacks, electroconvulsive therapy, they're also predisposed to posterior dislocation. Shepard's sign, where do you see that? In Blount's disease. So what is Blount's disease? It is endochondral ossification of the posterior medial proximal tibial physis. There is a disordered endochondral ossification, and that leads to tibia vara, internal torsion deformity of the tibia. Shepard's sign is basically, in extension, the knee is stable, but at 20-degree flexion, the medial femoral condyle subluxates into a posteromedial depressed tibial plateau. So even before X-ray changes are there, whenever Blount's disease is there, Shepard's sign will be typically positive. That's what you need to remember. Okay. So there are few interruptions happening, doc. Okay. Gun stop deformity. Supracondylar fracture of the humerus, you find the gun stop deformity is what you need to remember. Then James Steiner, who started advanced trauma life support, is originally an orthopedic surgeon. Ring sequestrum is typically found whenever any skeletal pin tract osteomyelitis develops. Amputation of the tarso-metatarsal joint, what do you call it as? Lisfranc's. If it is through mid-tarsal joint, you call Chopard amputation. And to the tarso-metatarsal, you call Lisfranc. So all these amputations and their proper nouns, you need to remember, doctor. Lisfranc operation through intertarsal, Chopard, talonavicular joint, Sims amputation to the ankle joint, Raise amputation, removal of the finger with respect to metacarpal from carpometacarpal. Krukenberg's amputation, making a forceps with 2 forearm bones. So they are the proper names which you need to remember. Osteoarthritis, what do you see now? You see interarticular cyst, subchondral cyst, marginal osteophytes, etc., etc., etc. So there's a narrowing of the joint space in osteoarthritis. Then subchondral sclerosis, subchondral cysts, marginal osteophytes, loose bodies, varus deformity, etc., etc. Whereas rheumatoid arthritis, there's a reduced joint space, subchondral cyst, juxtaarticular rarefaction, very characteristic feature. And there is a valgus deformity in rheumatoid arthritis. So what stabilizes joint, bursae, tendon, ligamental laxity, everything. Smith fracture is reverse Colles. It also involves the distal radial end of the radius at the cortico-cancellous junction, but there is a ventral tilt. There's a ventral tilt and ventral displacement. That's the reason it is called the reverse Colles fracture is what you should remember. So, doctor, we will take 5 minutes break. That brings us to the end of the first 50 questions. Pick up a pot of tea and we will rejoin after 5 minutes. Rejoin session after 5 minutes. Please invite your friends also to join this daily NEET PG mock test discussion. Right, Doc? We'll join after 5 minutes. So, welcome back to the session, doctor. Let us take the second part of our marathon. Right superior oblique. Typically is responsible for dextro depression. So it is right, so that is the reason it is dextro. And it is superior oblique, that's the reason it is depression. But remember, all obliques abduct and the horizontal recti adduct. All superiors intort, all inferiors extort. That is the favorite topic of point of examiner. Sclera is made up of dense irregular connective tissue. Mumps most commonly lead to dacryoadenitis is what you need to remember. And sunflower cataract, where do you see? Chalcosis, you find sunflower cataract. So all the proper nouns of the cataract, you have to be Dhanadhan, revised doctor. Snowflake cataract, young diabetics. Oil drop cataract, galactosemia. Sunflower cataract, Wilson's. Christmas tree pattern, dystrophia myotonica. Rosette-shaped cataract, blunt trauma. Glass blowers cataract is infrared radiation is what you need to emphatically remember, doctor. If there's a recurrent chalazion, you think of sebaceous gland carcinoma is a possibility. Krukenberg spindles you find in case of pigmentary glaucoma. So there's a pigment deposition in the endothelium in a vertical shaped distribution like a spindle, which is called Krukenberg spindle. So where do you see pigmentary glaucoma, doctor? It's a secondary open angle glaucoma. Young myopic males, it's very common. And there's a dispersion of the pigment in the corneal endothelium, which is called Krukenberg spindle. And if you do gonioscopy, you find Sample-Aziz line, where the pigment accumulates along the Schwalbe's line, is called as Sample-Aziz line. So this is how you find pigmentary glaucoma, gonioscopy showing the pigment along the trabecular meshwork. So this is called along the Schwalbe's line, Sample-Aziz line is what you see in case of pigmentary glaucoma. Non-granulomatous versus granulomatous uveitis, one of the favorite areas. So you should remember, non-granulomatous, acute onset, marked photophobia. Whereas granulomatous, marked visual impairment. Pain is very minimal in case of the granulomatous, whereas it is very marked in non-granulomatous. Granulomatous is usually the posterior uvea, whereas non-granulomatous is most often anterior uvea. Ciliary injection is marked in non-granulomatous. Keratic precipitates, fine white lymphocytic multiple, they're all non-granulomatous. Whereas large gray mutton fat KPs, keratic precipitates. Then aqueous flare, it is the flare that predominates, whereas the cells predominate in granulomatous. Iris nodules, Busacka nodules, they're all there in granulomatous. vitreous haze is marked in granulomatous, and the posterior syncytia are very thick and heavy in granulomatous. This important difference between these two types of the uveitis is the favorite question of the examiner. You should be ready for the tomorrow's exam, doctor. Green color blindness is called deuteranopia. Protenopia is red color, deuteranopia is green color, tetanopia is blue color, is what you should appreciate. Ortal slime, where do you see that? You see it in case of trachoma. So ortal slime is a linear scarring in the upper palpebral conjunctiva in the patients who are having trachoma. Now, if there's a recurrent bilateral conjunctivitis occurring in the hot weather, young boys with burning, itching, lacrimation, polygonal, raised, pebble stone-like appearance of palpebral conjunctiva, that is called vernal conjunctivitis. Vernal conjunctivitis is what you have to remember. Now, laryngeal TB, it presents with odonophagia and hoarseness of voice. Most commonly, it is the posterior part of the larynx where you find the presence of the classical lesions. Odonophagia, severe throat pain, is characteristic feature of laryngeal TB. Dangerous area of the nasal triangle, typically vestibule of the nose, corners of the mouth, extends to the bridge of the nose, is the dangerous nasal triangle, which has a direct communication with cavernous sinus. Cogon syndrome is unilateral deafness, keratitis, and vertigo. Viday neurectomy is done for the vasomotor rhinitis. Nasopharyngeal carcinoma is a radiotherapy because it's a squamous cell carcinoma. Most often, radiotherapy is highly radiosensitive. Ethmoidal sinus typically opens into middle meatus. In ASOM, where do you do myringotomy? It is the posterior inferior quadrant where the myringotomy is basically done. Acute retropharyngeal abscess. There is a swelling in the posterolateral wall of larynx. There is a torticollis. There is a dysphagia. In the children, it is a retropharyngeal lymphadenitis. Because of the upper respiratory tract infection is most often the underlying cause for the acute retropharyngeal abscess is what you should remember. Cricoid hook, where do you use that? Particularly in tracheostomy. Tomorrow, NEET PG में image based MCQ आने वाला है. Cricoid hook. Once more, doctor. Surgical instruments, obstetrical, gynecology instruments, suture material, they're all very hot topics. You have to go back to the Incus learning app and download the Incus learning app. 2000 HD videos, each containing 20 to 25 minutes of review class, along with the PowerPoint is already there. So every day 5 to 10 topics pakadna, where you are going wrong, just go back and do the revision. Low tracheostomy, where is it indicated? When juvenile laryngeal papillomatosis. Below the level of the isthmus, you call low. So, P to P1 lady, 34 weeks pregnancy, comes with PROM, premature rupture of membranes. What do you want to do? Induction of labor. So the term PROM means when rupture of membrane occurs beyond 37th week, but before the onset of labor. Preset PROM means preterm PROM, means before 37 completed weeks. Prolonged rupture means rupture of membranes for more than 24 hours before the delivery is what you need to remember. So, doctor, how do you manage different types of rupture of membranes? If it is term and more than 37 weeks, then induction of labor, antibiotics if needed to prevent the GBS transmission. If it is a late preterm, then 34 to 36 weeks. Once more, induction of labor. Preterm, 24 to 33. If there is a rupture of membrane, amniotic fluid came out, then watchful waiting, antibiotics, one-time dose of steroid if it is before 34 weeks, antibiotics, that is the management. If it is pre-viable, less than 24 weeks, so no antibiotics, corticosteroids, tocolysis or max sulfate, and patient counseling about watchful waiting or induction of labor. So that is how, based upon the fetal term, you manage the PROM. So third stage of labor, uterine massage, IM oxytocin, controlled cord traction of Brandt and Drew's maneuver. They're all indicated. Methergin 0.2 milligram IM is given within 1 minute of delivery of the baby. That's the point you need to appreciate. Max sulfate is contraindicated when? How do you recognize that there is a max sulfate toxicity? If the knee jerk is absent, if the diastolic BP is less than 90 and urine output is less than 30. So whenever max sulfate toxicity is there, oxygen saturation falls, respiratory rate becomes less than 14 or more than 24, tachycardia or bradycardia, or any pulmonary edema with a change in breath sounds, they are the things that need to be monitored. Similarly, any absent DTRs or urine output less than 30 ml, any change in the fetal heart rate pattern, etc., etc. So what is the therapeutic level of serum magnesium is the examiner's favorite question. 4 to 7 milliequivalents per liter is what you should remember. Use of the OCPs, it decreases PID, epithelial ovarian cancer, and ectopic pregnancy. So reduced ovarian cancer, reduced endometrial cancer, reduced ectopics, reduced benign breast disease, reduced functional ovarian cysts, and reduced uterine fibroids. They are all the benefits of OCPs. Less dysmenorrhea, less anemia, reduced PID, reduced risk of colon cancer with OCPs. But, what cancers can occur because of the OCPs? Cervical cancer, liver cancer, breast cancer, precancers, don't forget. Now, in pregnancy, what is the drug of choice, doctor? Methyl dopa, labetalol, nifedipine. You should not forget these names. So, what is the best way to measure fetal macrosomia? Big baby. It is the abdominal circumference, which is used to estimate. Triple test, AFP, HCG, estriol, they're all included. The mucin deposits in the ovary, commonly due to adenocarcinoma of the appendix. Isoimmunized lady with one child comes with 25-week pregnancy with fetal ascites. What do you want to do? You need to do amniocentesis. So if you want to know the severity of the isoimmunization, amniocentesis. It is usually performed at least 4 to 8 weeks earlier than the prior gestational age where the morbidity happened. Then you have a Lilly curve. Zone 1, mild disease. Zone 1, fetuses are followed once more with amniocentesis every 3 weeks. Zone 2, intermediate disease. If the fetuses are in the low zone 2, they are followed every 1 to 2 weeks. Middle of the zone 2 require transfusion or delivery. So that is how you approach. Lilly's curves, amniocentesis, RH isoimmunization. Today only you have to go back to the Incus learning app. And in that 2000 HD video ka program ko revision karna. In PPH, in lady taking highly active antiretroviral therapy, we use prostaglandin E1. Group B streptococcal infection. You do a screening prophylactically in all cases between 35th to 37th week. So what is this fetal heart rate pattern? So you should look at where is the deceleration or acceleration in relation to the contraction of the uterus. So it is a late deceleration with a flat baseline. So you all know cord compression lead to variable deceleration. Then head compression lead to early deceleration. And fetal hypoxia lead to the late deceleration pattern is what you need to remember. Laparoscopic salpingostomy versus laparotomy with salpingectomy. What is the difference? Mainly it is the hospital stay. Laparoscopy is like a focused keyhole surgery. Obviously, there is a decreased hospital stay. A 30-year-old G1 P0 with twin gestation at 25 weeks, presenting with labor, irregular uterine contraction, back pain, and there are uterine contractions every 2 to 4 minutes. She is afebrile, her gravid uterus is non-tender. What are the next steps you want to do? So always, twin gestation, symptoms of bleeding, cramping, increased vaginal discharge. If it is there, then it is preterm labor. IV hydration is appropriate because dehydration can cause premature contraction and uterine irritability. Urinary tract infections may be associated with uterine contractions. Group B streptococci can be responsible for preterm labor. So they all should be identified and managed. A healthy 44-year-old from Bijapur presents to the labor at 30 weeks of gestation, small amount of bright red color per vagina, and the bleeding has completely resolved when she arrived. She denies any regular uterine contraction, but says, I'm having cramping. She had normal screening sonogram at 20 weeks as part of her routine prenatal care. How do you want to manage? So in summary, this patient gives a history of vaginal bleeding in the 3rd trimester, and she should undergo the ultrasound as the first step in evaluation because you want to rule out the placenta previa. If there were to be placenta previa, doing a speculum examination is invitation to a catastrophic hemorrhage. That's the reason ultrasound should be the first. A 24-year-old diagnosed with toxoplasma, how did she get? It is the raw meat eating is most commonly associated. 38-year-old with a rash on her abdomen, increasingly pruritic, 37 weeks gestation. There are stretch marks, red papules, plaques. And this is her typical picture of the lesions which you are able to see. So what is the likely diagnosis? It is a PUP, pruritic urticarial papules and plaques of pregnancy. It is the most common dermatological condition of pregnancy. It is more common in nulliparous women, most often in the second and third trimester of pregnancy. There is an erythematous papule and plaques which are intensely pruritic and appear first on the abdomen. They spread to the buttocks, thighs, and extremities. They spare the face. Then what is the other differential diagnosis? Herpes gestationalis. It is a blistering skin eruption, multiparous women, second and third trimester of pregnancy. The vesicles and bullae, which are the features of herpes gestationalis, is not the feature of POP. That is the differentiator. Prurigo gestationalis. Small pruritic excoriated lesions that occur between 25 and 30 weeks on the trunk and forearms. Then very important condition you should not forget, doctor. Intrahepatic cholestasis of pregnancy. Typically in the pregnancy, the bile acids are cleared incompletely. They accumulate in the dermis. That causes an intense itching, and they develop the pruritus in the late pregnancy, is what you need to remember. Then impetigo herpetiformis. This is a pustular eruption along the margins of erythematous patches. This also occurs in late pregnancy. Usually these lesions are all on the flexures and extend peripherally. Mucous membranes are involved. But with impetigo herpetiformis, one important point you should know is, unlike in intrahepatic cholestasis of pregnancy where pruritus is very intense, it is not that intense, which is a differentiator. 37-year-old at 10 weeks of gestation with Graves' disease maintained on propylthiouracil. The infants who are born to the mothers on PTU, they may go into hypothyroidism with a goiter and become clinically hypothyroid, is what you need to remember. A 41-year-old G1 P0, 39 weeks, completely dilated, pushing for 3 hours. She has an epidural in place. She is exhausted, crying. Temperature is 101. Fetal heart rate is in 190s. Decreased variability. The patient's cervix is completely dilated, effaced. And the fetal head is in direct occipital anterior position. And it is visible in the introitus between the pushers. Extensive caput formed. So, what kind of the forceps you want to use to do the delivery is a very, very important question. So, you should know how a Simpson's forceps looks like. It is usually a low or a outlet forceps delivery. Then Killian's forceps is used for mid-forceps delivery, and you can be able to rotate, do the rotation of the fetal head. Piper's forceps is designed to deliver the after-coming head during the vaginal breech delivery. So examiner, tomorrow's NEET PG में one of the forceps अगर नहीं दिया तो मेरा नाम मुरली भारद्वाज नहीं है. बराबर? So doctor, Killian's forceps versus Piper's forceps. Killian has a small pelvic curve, sliding lock, suitable for the head with little molding. It is most common forceps used for rotational delivery, helps in correcting the asynclitism. Whereas Piper's distinct perineal curve allows for after-coming head in the breech delivery. Now a 25-year-old, 41 weeks, painful uterine contractions every 2 to 3 minutes, her cervix is, the feet is palpable. So that is called footling presentation. In footling presentation, no role for, in a footling breech, there is no role for the normal labor. Emergent cesarean section need to be done. So the frank breach, complete breach, footling breach. Now, cranial tumors or hypothyroidism, what they can lead to? True sexual precocity. भैया ट्रू सेक्सुअल प्रिकॉसिटी क्या होता है? नॉर्मल, टिपिकली ए नॉर्मल so a normal gonadotropin levels and a normal ovulatory pattern, it represents premature activation of the normally operating hypothalamic pituitary axis. So where do you see it? There can be cerebral causes like tumors, encephalitis, meningitis, hypothyroidism, neurofibromatosis, etc. Now, what is meant by isosexual precocious pseudopuberty? Whenever there is excess amount of estrogen in a female because of any underlying neoplastic conditions or endocrine gland problems, then it is called isosexual precocious pseudopuberty. But if it is a male sex hormone, testosterone producing endocrine condition in a female, then that is called heterosexual precocious pseudopuberty. So the most common cause of the isosexual precocious pseudopuberty in the female is estrogen producing ovarian tumor, like dysgerminoma, choriocarcinoma, any of them. 32-year-old multigravida complaints of bleeding between her periods. For the past 9 months, she has 2 dilatations and curettages. They have failed to resolve the symptoms. OCPs, antiprostaglandins, they have not helped. So how do you want to manage? You have to do a hysteroscopy. उसके अंदर क्या है? His uterus के अंदर क्या है? That is what you need to look for. So hysteroscopy can rule out any endometrial polyp, small fibroids. If they are there, they can be resected. Danazole, what does it do? Typically, it leads to atrophy of the endometrium. 32-year-old, you are able to see what? Lot of synechia of Asherman. So that presents with hypomenorrhea, decreased amount of functional endometrium and lighter amount of menstrual blood flow. A 40-year-old woman who had 2 pregnancies 15 and 18 years ago presents with the complaints of amenorrhea for 7 months. She wants to become pregnant. After exclusion of pregnancy, which test is next indicated to evaluate her amenorrhea? So this patient has secondary amenorrhea. So chromosomal anomalies, congenital Mullerian anomalies, they're all causes for the primary amenorrhea, not secondary. And the most common reason for amenorrhea in a woman of reproductive age is pregnancy. And the other possibilities are Asherman syndrome, hypothyroidism, ovarian failure. So that is the reason you need to do LH and FSH levels. A 19-year-old medical student who has recently become sexually active developed a severe primary dysmenorrhea. She doesn't want to be pregnant. So which medication is appropriate? Oral contraceptive. So whenever a patient has dysmenorrhea, they have a significantly high amount of prostaglandins in the endometrium and menstrual fluid. So prostaglandin inhibitors like indomethacin, naproxen, ibuprofen, mefenamic acid are very effective. But for the patients with dysmenorrhea who are sexually active, OCPs will provide protection and also they alleviate the dysmenorrhea. That's the reason. 1 bullet, 2 birds. Hysterosalpingogram, which is being shown to you, What is this condition called? It's called salpingitis ischemica nodosa, which can occur in normal women. To know the serum progesterone level to document the ovulation, what is the best time? In a 28-day menstrual cycle. So 14th day is ovulatory day, usko 7 days add karo, day 21 is the appropriate time. A 22-year-old G0, P0, sparse hair around the nipples, chin, upper lip, no galactoria, thyromegaly, temporal balding, nothing is there. No evidence of any clitoromegaly. What she is having is only acne and hirsutism. So it can be idiopathic hirsutism, it can be polycystic ovarian syndrome, it can be a late onset congenital hyperplasia, but it is not certainly Leydig cell tumor. If it is there, then you will have temporal balding, clitoral hypertrophy. Any of them can be there because certainly Leydig produces a very high level of testosterone, is what you need to remember. So what is the effect of estrogen on the lipid profile? So estrogen offers a natural protection against heart attack, atherosclerosis, coronary artery disease. Why? Because estrogen increases the HDL levels, is what you need to remember. So, doctor, that brings us to the end of this marathon. Every day, morning grand test ले लो, शाम में discussion attend करो. 40 days, 4,000 MCQs we will have discussion. 170 out of 200 will come from these 4,000 questions only. Right? But what you need to do after this session is over, 10 topics pick up karo. Go back to the Incus and do the revision. Good night and see you all tomorrow. Thank you.